Dear students, in this video, I am going to discuss about insulin therapy in ICU, something which we are all aware of, but still there is some confusion regarding the means and the ways of starting the therapy and maintaining this same. So let me start with the case. A 64-year-old male who is a known case of type 2 diabetes for 10 years and is currently on metformin and premixed insulin 30 by 70, 24 units in the morning and 16 units in the evening, and also with hypertension and stage 3 CKD, presents with fever, productive cough, and altered sensorium for a day. He is diagnosed as community-acquired pneumonia, who is admitted in the emergency department and subsequently, over a course of time, reaches the ICU. In the ICU, the patient is sedated on noradrenaline 0.2 mics per kg per minute on lung protective ventilation. Enteral nutrition has been started through NG tube at 20 ml per hour and is planned to advance. The bedside capillary glucose readings during the first 3 hours are 342, 328, and 310 milligram per deciliter, despite one subcutaneous correction dose given in the emergency department. Now, the question is, how will you outline a plan for glycemic target and insulin strategy? So, to do that, you have to know the evidence and the current targets. In the early days, like Leuven surgical ICU trials had shown that intensive insulin therapy with a target of 80 to 100 milligrams per deciliter reduced ICU and in-hospital mortality and complications in patients who were staying for more than 3 to 5 days. But later, larger and mixed ICU data, like the NICE sugar study, and the systematic reviews found that there is no overall mortality benefit of intensive control. And in fact, there is more hypoglycemia with greater mortality at times. So the current guideline direction, both by American Diabetes Association and the critical care reviews, is to start insulin when persistent glucose is more than 180 milligram per deciliter in critically ill patients, and maintain in most ICU patients the blood sugar between 140 to 180 rather than 80 to 110, which was done before. So in order to do so, we administer insulin in the ICU for hemodynamically unstable or ventilated ICU patients. IV regular insulin infusion is preferred because it has rapid onset and offset and it can be easily and quickly titrated. Continuous IV insulin is considered generally superior to intermittent subcutaneous doses of insulin for achieving stable glycemia in critical illness, but still subcutaneous insulin is still used in some units, although it is not recommended as the first line for unstable patients. Long-acting or basal insulin like glargine, they may have a role in more stable ICU patients or during transition out of ICU, but evidence and practice patterns vary worldwide, and even in the same hospital, sometimes between the different ICUs, the different specialty ICUs, also the practice pattern varies, and high dose infusions unequivocally in all setups have been associated with more hypoglycemia and longer time to target or to achieve the target. So, in a septic vasopressor dependent patient on tube feeds, an IV insulin infusion protocol is usually chosen initially, with later addition of basal bolus subcutaneous regimes as they stabilize. So, what should be the practical ICU insulin protocol? Now, the protocol can vary from institute to institute, but the basis of making such protocol remains unchanged. So, if we have to reach such read such a protocol and follow such a protocol, you have to go through certain steps. The first steps is to assess the patient and the context, like pre-existing diabetes versus purely stress hyperglycemia. If we see that the patient is having a pre-existing diabetes, then the requirement of insulin will be much higher and much for a longer duration of period. And it will also take time to nadir. So therefore, we need to start with subcutaneous. We start with soluble insulin, that is intravenous insulin, and then gradually, as we are able to control the diabetes, we switch to them. In contrast, in purely stress hyperglycemia, it may be very easy to achieve the control with small or shorter bouts of insulin. Nutritional status, whether the patient is NPO, enteral feeds, parenteral nutrition, or variable in oral intake, because that will have an influence on the occurrence of hypoglycemia and also the episodes of hyperglycemia. Organ failure, including vasopressors, steroids, infection, they are all likely to derange the metabolic system, and therefore they will require higher doses of insulin. So after assessing the patient and the context, the next step is to set a glucose target. Most ICUs set the target as 140 to 180 milligram per deciliter. Selected post-surgical or neuro cases may use slightly lower targets like 110 to 150 if hypoglycemia risk can be tightly controlled. The next stage is to start insulin. If the glucose is more than 180 milligram per deciliter on two readings, start IV regular insulin infusion using a standard weight and sensitivity based protocol. Avoid IV bolus doses unless protocolized because of the risk of overshoot. Next is the monitoring. You have to check capillary or arterial glucose at least every 1 hour when starting or changing the rates, and spacing to every 2 to 4 hours once the patient is stable in terms of blood glucose level. And have a written or electronic titration algorithm to adjust the infusion rate based on the current level, rate of change, and the nutritional status of the patient. Next important step is the prevent and manage hypoglycemia. We have to clearly define hypoglycemic thresholds. For example, less than 70 milligram per deciliter, and the treatment steps like first to stop insulin, give IV dextrose, recheck in 10 to 15 minutes, etc. And those should be meticulously followed. Protocols should include how to respond to feed interruptions or changes in the vasopressor dose, because that is also going to affect the sugar level and thereby will necessitate change in insulin. The next is to identify the transition plan. That is, once the patient is hemodynamically stable and is eating or on stable feeds, the transition to subcutaneous basal dose should be done. That calculate the total IV insulin over the last 24 hours and give 50 to 80% of that as total daily subcutaneous dose, split into basal plus prandial correction. And second, also remember to overlap the IV and the first basal dose given by subcutaneous route by 1 to 2 hours to avoid rebound hyperglycemia. So why is IV infusion preferred in the unstable ICU patient? A question which is very often asked in the exam. We have to answer with these four headings. One is the rapid onset and offset, so that the rate can be adjusted frequently as hemodynamics, vasopressors, or nutrition change in such patients. And this is crucial in any critical illness in the initial 24 to 48 hours. Secondly, there is predictable delivery despite shock. In septic shock or when patients are on vasopressors, peripheral circulation is poor, as we know, and subcutaneous absorption is unreliable. So there is irregular absorption leading to erratic glucose control and greater risk of hypoglycemia. And IV infusion can bypass this problem. Third, fine titration using protocols. Standardized IV insulin protocols allow small rate changes. Rate changes such as 0.5 to 2 units per hour or such steps based on the current glucose and trend. So this is very important and useful in various clinical situations. And last but not the least, their easier response to nutrition and changes, like with tube feeds or TPN or frequent interruption of feeds. IV insulin can be promptly increased, decreased, or stopped to match the carbohydrate delivery. And that will also reduce the risks of both hyperglycemia and hypoglycemia. Next is when to consider switching to subcutaneous basal bolus. The common criteria which all or most of should be met in the patients are the patients should be off vasopressors or on minimal vasopressors with stable doses and hemodynamically more or less stable. Second, no planned interruptions of nutrition are there, eating reliably or on stable enteral feeds or TPN for at least several hours. Third, glucose is reasonably controlled on a relatively stable IV insulin rate. No large rate swings in the last 6 to 12 hours have occurred. And fourth, no recent severe hypoglycemia events and acceptable renal and hepatic status for subcutaneous dosing. So these common criteria should be met before we consider switching to subcutaneous basal bolus doses. If any of these are not met, like feeds on off, vasopressor changes, continuous IV infusion is usually safer. Now, how to safely transition from IV infusion to SC basal? So, the first decide on the total subcutaneous insulin dose. A common approach is to calculate the total IV insulin used over the previous 24 hours or extrapolate from a shorter stable period like 6 to 12 hours. Then take about 50 to 70% of that amount as the initial total daily subcutaneous insulin dose to reduce hypoglycemia risk. For example, if the patient needed 60 units via IV infusion in the last 24 hours, start with 30 to 40 units per day of subcutaneous insulin, basal long acting, and some studies in critically ill patients found best control with basal doses of around 50 to 59% of the prior 24-hour IV requirement and with a fewer hypoglycemic episodes. Other way is to split into basal and bolus components. For patients who are eating or on regular bolus feeds, give roughly 50% of the calculated total daily dose as basal insulin, that is glargine, and 50% split as prandial plus correctional rapid-acting insulin before meals or feed boluses. In patients who are NPO but on continuous tube feeds or on TPN, many protocols give most or all of the daily dose as basal insulin plus small scheduled or correctional rapid acting doses depending upon the feed carbohydrate content and the glucose trend. So how to safely vessel? The other important way is to time the first basal dose and overlap with IV infusion. This is important to avoid rebound hyperglycemia. So we should not stop the IV infusion at the exact moment when we give the basal dose. The practical steps is to administer the basal insulin like glargine, continue the IV insulin infusion for another 1 to 2 hours, or according to some protocols is maybe 2 to 4 hours to allow the basal insulin to start working. After that overlap period, you stop the IV infusion if glucose remains in range and the patient meets stability criteria. Some hospital protocols specify, like give basal insulin at least 2 hours before discontinuing IV insulin, include a small bridging rapid acting dose like 10% of the basal in selected patients at high risk of post-switch hyperglycemia, and so on. Then post-transition monitoring and dose adjustment. The first 24 hours after transition are high risk for both hyperglycemia and hypoglycemia. So check capillary blood glucose before meals and at bedtime, or every 4 to 6 hours if on continuous feed. Then use correctional rapid-acting insulin or out of range values and adjust the next day's basal or bolus doses based on the trends. If repeatedly the levels are high, like more than 180 to 200, despite reasonable subcutaneous doses, Or if clinical instability recurs, like feed stopped, new sepsis, then you have to consider restarting IV insulin infusion. So, how to titrate the infusion? If the glucose is above the target and falling slowly or not falling, you increase the rate by small steps, that is 1 to 2 units per hour, depending on how far above target and how flat the trend is. Second, if glucose is within target, that is between 140 to 180 mg per dl, in that case, we have to maintain the current rate or make very small adjustments and alongside repeat hourly glucose. Third is if the glucose is falling too fast, for example, more than 60 to 75 mg per dl drop in 1 hour, but still above target. So in those cases, you reduce the infusion rate to avoid overshooting into hypoglycemia. And fourth, if glucose is below target or near hypoglycemia, like between 70 to 100, you decrease rate significantly or temporarily hold, consider extra dextrose. For below 70 milligram per dl, stop infusion immediately, give IV dextrose as per hypoglycemia protocol, recheck in 10 to 15 minutes, and then restart at a lower rate once the value is around 100 milligram per deciliter. So if we apply this to our septic shock case, we have to start by preparing IV regular insulin 1 units per ml, begin infusion around 2 to 4 units per hour, like 3 units per hour as per ICU protocol with hourly glucose checks. Ensure the tube feeds are running. If there is any chance feeds will stop, have a dextrose plan to prevent hypoglycemia when the insulin is on. In the first few hours of titration, if the glucose stays more than 250 milligram per deciliter and falls less than 50 milligram per deciliter per hour, then increase the rate stepwise, like to 4 to 5 units per hour. If the glucose comes into 140 to 180 mg per dl level, then maintain the rate or make small adjustments. Or if continue hourly checks until 3 to 4 consecutive readings are in the range of a relatively stable dose. So getting a stable dose alone is not sufficient. It has to be continued for 3 to 4 consecutive readings after reaching the stable dose. And later, once hemodynamically stable and rates are not changing much, you have to space monitoring to 2 hourly, still using the protocol to adjust for trends, feed changes, or vasopressor changes. So my final take-home message would be that always use protocol-driven IV regular insulin infusions in unstable ICU patients, aiming for a moderate glucose target of 140 to 180 mg per dl and avoid large IV boluses. Start at a slow rate, for example, 2 to 4 units per hour in 25 to 350 milligram deciliter range and titrate hourly based on current value, trend, existing rate, and using a standard algorithm. Always prevent hypoglycemia with frequent monitoring, clear the correction steps, and careful coordination with nutrition is vital, especially feed interruptions. And last but not the least, once hemodynamics, nutrition, and insulin needs are stable, transition to SC, that is subcutaneous basal bolus regime, using about 50 to 70% of the prior 24-hour IV insulin requirement with a 1 to 2 hour overlap between IV and the first basal dose seems to be really prudent. Thank you very much.